Hi, I'm Frank Spear. I want to welcome you to this segment. What we're going to talk about in this segment, I think, is one of the most critical elements of anterior aesthetic restorative dentistry, and that is how do we manage our restorative margins when they need to be placed subgingivally. There are just certain restorations and certain instances where we're not going to get a good aesthetic result unless we place our margins below tissue. If we have really discolored teeth, for an example, if we're using restorative materials that by their nature are a bit more opaque, like metal ceramics or zirconia, or in some cases lithium disilicate or alumina, we're going to need our margins below tissue unless we're going to see a very distinct line between our margin and the tooth preparation. So what I'd like to talk to you about in this particular section is how do we actually manage the technique aspect of placing a margin below tissue, and what are the concerns that we need to look at. Now, in the previous section, I had taken this patient, Connie, and I had prepared her two central incisors, basically through the steps of incisal reduction, facial reduction, interproximal reduction, lingual reduction, all the way to the place of putting the margins below tissue. So we had looked at the two centrals. They had some large composites on the mesial. It went through the interproximal and onto the lingual. And I'd made the decision to actually do them as full coverage restorations. And essentially, this is where we had left off, is the preparations were at that stage. And we had talked about, do we leave them supragingival, equigingival, subgingival? And my choice of restorative materials for her is either going to be lithium disilicate or lucite reinforced pressed ceramic. That decision was based on the fact that her preparation color is actually quite nice. So I don't really have to mask anything. They're a little dark, but not horrendously so. And I've prepared them with 1.2 millimeters of facial reduction. So I know the technician will have room to adequately manage the color. Now we're at the point where we need to decide, do we or don't we go below tissue? And in her instance, my decision is yes, I'm going to, because I really want the absolute best aesthetics for her. She has a very high lip line. And if I leave them supragingival, probably she is going to notice that the margins are visible. And so my decision is to go ahead and place them below tissue. So as soon as I say that, we ultimately have to think about biology, and we have to think about what are our concerns when we go to place a margin subgingivally. And really there's two major concerns. The first concern is we know that biologically the body has a connective tissue attachment and an epithelial attachment, and those two combined make up what we call biologic width. And we know that if we put our margin too deep, and we actually put our margin within that zone of attachment, that the body has two choices typically. It either responds with inflammation or it responds by resorbing bone. More commonly, it responds with inflammation, and we get nice red tissue around our restorations. So we don't want to go too far below tissue. If we go too far below tissue, we risk the attachment violation. On the other hand, we know there are patients who, after we do our manipulations restoratively, get some recession. And if they get some recession, we have a new risk. And the new risk is now we do have a supragingival margin. Now, if it's a translucent margin, it may not be such a big issue. But if it's a margin that's more of an opaque material, it could be a really big issue, especially if it's a margin that has either a dark or a white line. So we also can't go too shallow, because if we go too shallow, or if you will, not deep enough, we risk that if there's any recession at all, our margin now is supragingival. So what we really need to be able to understand all of this is we need to understand better the biology, more specifically the variations in biology between patients. Because it's those variations in biology that's the reason we can't just have one approach to how to prep margins. So if we go way back 50 years ago to when this paper was published by Gargiulo, Wentz, and Orban, where they took cadavers and they block-sectioned them and they looked at the anatomy, if you will, of the dental-gingival junction. And they're the ones that discovered the connective tissue attachment was basically 1 millimeter in height. The epithelial attachment's a 2 millimeter in height. A year later, D. Walter Cohen at the University of Pennsylvania called these two combined biologic width. And we also know that in the typical patient, there's about 1 millimeter sulcus. What I was taught in the 1970s when I was in dental school and graduate school was that this basically is the biology of a human. And therefore, you got about 3 millimeters of tissue above bone. And if you have 3 millimeters of tissue above bone, 2 of which is the attachment, and 1 of which is sulcus, then the way I was trained to place margins below tissue was in fact to use the bone as my reference point. So my training was to find out where the bone is, and then to put your margin of your preparation 2.5 millimeters from the bone. The concept being that if your margin's 2.5 millimeters from bone, it won't be in the attachment, because the attachment's only 2 millimeters tall, but it also will be covered by gingiva, because the gingiva is 3 millimeters above the bone. So 2.5 millimeters from bone was a very logical thing to do. The trouble was some patients got recession and some patients got inflammation. And you kind of were like, well, it works sometimes, but not all the time. It really wasn't until 1994 when a fellow from the military named Vasic redid Gargiulo, Wentz, and Orban's research. But what Vasic did is he published the ranges of biologic width. So he said, yep, on anterior teeth, the average biologic width is around 2 millimeters. Premolars, the same. Molars, the same. On the facial, lingual, mesial, distal, it's pretty consistent. But he discovered that there was a big range between humans, so that some had biologic widths that were only 1 millimeter or less in height, 0.7 of a millimeter in height. Others on anterior teeth were 3.5 millimeters in height. And so suddenly when you look at the range of biologic width, you start to understand why there's variations in how patients respond when we place margins below tissue. Now here's what we know about a human for sure. If you cut the gingiva off to bone, totally remove it, like we used to in the 1970s in our, quote, pocket elimination surgery, where we would put the tissue right at the level of the bone, the body will in fact grow back gingiva. They'll grow back connective tissue attachment, they'll grow back epithelial attachment, and they will regrow a sulcus. So we know the body is going to keep those 3 things. Now, we also know that not every patient grows back the same amount. Those that have an average biologic width of 2 and a millimeter sulcus tend to grow back closer to that 3 millimeters of gingiva. But people that have deeper biologic widths may end up growing back more tissue. So we may have patients that come in our office who have a 2 millimeter connective tissue attachment and a 1 or 2 millimeter epithelial attachment. Their biologic width is actually 3, and then they may have a sulcus on top of that. They may have 4 or 5 millimeters of tissue above bone. Now, what happened in my early days when I would put my margin 2.5 millimeters from bone? Okay, there's our 4 millimeters of total tissue in this example. I put my margin 2.5 millimeters from bone because it's what I was trained to do. And in fact, my margin is right in the attachment. And we end up with inflammation. Now, do we get recession? No, not unless we lose bone. The body doesn't get recession unless we lose bone. The tissue won't recede into the bone. You have to have apical migration of the attachment to get recession. And you can't get apical migration of the attachment if the bone is in the way. And so instead of recession, when we violate biologic width, we typically never see recession. What we see is inflammation. But there are times we do get recession. And so it's important to recognize who are the patients that we get recession in. It's obvious in this patient that if they have a 3 millimeter biologic width and 4 millimeters of tissue, that my margin shouldn't be 2.5 from bone. It should in fact be 3.5 from bone. And now I won't be in the attachment, but am I at risk of recession? Remember what I said. For you to get recession, you have to get a migration of the tissue apically. So let's look at the examples of who gets recession and who tends to not get recession. If we have two examples, each with 5 millimeters of total tissue above bone. So that example has 5 millimeters of gingiva above bone, so does this one. But the one on the left has a 3 millimeter deep sulcus, a 2 millimeter biologic width. The one on the right, a millimeter deep sulcus, a 4 millimeter biologic width. Who is likely to get the recession? The one on the left. People who are at most risk for recession following restorative procedures are patients with deep sulcuses. They have unsupported tissue. That tissue can easily recede, but it will stop. Where will it stop? It's going to stop at least a 1 millimeter sulcus. You're never going to recede so there's a 0 sulcus. The body's going to maintain biologic width and maintain a sulcus. We know that because we know if you cut the tissue away, you always regrow at least a millimeter sulcus. And so with this knowledge, we have to rethink how do we prep teeth. Honestly, what it meant to me is you can't use the bone as a reference. Because using the bone as a reference only works if you actually knew the patient's biologic attachment height. And we don't. And so in 1994, I really changed the way I thought about tooth preparation to now use the sulcus depth as my reference for tooth preparation. Now the trouble with that is we know that sulcus depths vary. We know that it's not a precise measurement. Why is that? Well, Sokransky showed us years ago that when you probe the sulcus, your probe penetrates the epithelial attachment at least a 0.5 millimeter. And if your gingiva is inflamed, it even penetrates the epithelial attachment more than that. So we have to understand that we have to be working from healthy tissue when we talk about all of this. If we're talking about inflamed tissue, we're at real risk because our probing depths may be very inaccurate. So if we have a lot of tissue inflammation, we need to control the inflammation before we think about precisely placing a subgingival margin. But let me share with you my basic rules that I've used since about 1994 for how I place margins subgingivally. Now, if they don't need to be subgingival, then great, don't even bother with it. But when they need to be subgingivally placed, rule number 1 for me is if I have a shallow sulcus, a shallow sulcus is to me anything less than 1.5 millimeters. So that means to me, I know my probe is probably partway in the attachment. If I have 1.5 millimeters sulcus, what am I not likely to get? I am not likely to get recession. Or if I get recession, it will only be a few tenths of a millimeter. Because again, the sulcus isn't going to disappear. The tissue is not going to recede into the attachment. So if I have 1.5 millimeters sulcus, what I will do is put my margin 5 to 7/10 of a millimeter subgingivally. That way, if I do get a few tenths of a millimeter recession, my margin's still covered. But I'm not in the attachment. By only going 5 to 7/10 below tissue, if I have a 1 to 1.5 millimeter sulcus depth, I know I'm not in the attachment. Now, what about the sulcus that's 2, 2.5, 3 millimeters? That sulcus is the sulcus that's at risk of recession. So you have a couple of choices. If you choose to leave the tissue where it is, what I do is I prep my margin half the depth of the sulcus. So if I had a 2 millimeter probing, I would put my margin 1 millimeter below tissue. If I had a 3 millimeter probing, I'd put my margin 1.5 millimeters below tissue. Why? Because this is the tissue that's most likely to recede. And I want to have the chance that if it does recede, my margin is still protected. Now, what's the alternative? The alternative is to remove the risk of recession. And how do we remove the risk of recession? By doing a gingivectomy. If we tape a deep sulcus, a 2 to 3 millimeter sulcus, and we do a gingivectomy so we leave a 1 to 1.5 millimeter sulcus, we've taken away the risk of recession. What we know is statistically, if you do a gingivectomy, statistically at a year, half of it's going to grow back. And so when we take a 3 millimeter sulcus and we do a gingivectomy to leave 1.5 millimeters to 1 millimeter sulcus, and now we put our margins 1/2 to 7/10 below tissue, if we do that, now we basically have eliminated the risk of recession. So the way I look at subgingival margin placement is probe the sulcus. If it's 1.5 or less, go 5 to 7/10 below tissue. If it's deeper than 1.5, consider a gingivectomy to convert it to a shallow sulcus, and then go 5 to 7/10 below tissue. Why would you not do the gingivectomy? If doing the gingivectomy would make the teeth too long. If that's the case, then you're going to follow Rule 2 and you're going to go half the depth of the sulcus and hope the tissue doesn't recede. So, getting back to our patient Connie, we had left the teeth prepared right to the tissue margin, and I made the decision, because I'm trying to maximize the aesthetic result, that I don't want to be able to see the junction between the margin and the tooth supragingivally. So I'm going to go subgingivally. So what do I need to do to know how to place my margin? I need to probe the sulcus. So if you watch, here's the video, and I simply am going in and I'm checking the depth of the sulcus on both centrals, and it's coming out at 1 to 1.5 millimeters on both centrals. Now remember, what I said is the probe is probably going 1/2 millimeter into the attachment. And so we may really not have 1.5 millimeter true deep sulcus. That's why we're only going to go 5 to 7/10 below tissue. Now, the question is, how do you do that? And, you know, just like there's a lot of different restorative materials that work, there's different adhesives that work, there's different methods of controlling subgingival margin placement. It's very in vogue for the last 5 to 10 years to no longer use retraction cord, to use lasers in particular for all of your retraction. And in the office, we have 3 different lasers. We have electrosurge. I can tell you when it comes to anterior teeth, I still use retraction cord. And the reason I use retraction cord is because it really allows me to control very precisely my margin placement. I'm not saying you can't do it the other way. There's obviously a lot of people out lecturing that don't use cord at all. And primarily they do it because they think it's faster to not use the cord, to do it with troughing with a laser. But my bias is when I really want to control margin placement very precisely, I still prefer retraction cord. So the trouble with retraction cord is this. As soon as you place it in the sulcus, it moves the tissue. And when the tissue moves, now you don't know where the gingiva was anymore. So what we did in the first section on Connie was we prepped the tooth exactly even with the gingival margin, as close to the tissue as I can get without hitting it. Why? So that now when I put in my retraction cord, this prep margin, this previously prepared margin, it's my reference for where the free gingival margin used to be sitting. Now, once we've got it there, and if you look at the photographs of Connie's preps, you can see the prep margins are right even with the tissue. Once I've got it there, I'm now going to intentionally retract the tissue to allow me to move the margin more apically on the tooth. And what I'm going to do is I'm going to use cord, not that you couldn't use those other things as I said, but I'm going to use cord to give a very controlled margin placement. And the cords I've used for I don't even remember how long are UltraPack cords from the Ultradent people. I use a non-impregnated one that's just soaked in some aluminum chloride, but certainly impregnated ones work fine as well. My most common cord for veneers would be a double-aught. My most common cord for full crowns would be a number 1, which is the blue cord. So what I'm going to do in Connie is I'm going to take the number 1 cord, use a very, very small packing instrument. Ultradent makes actually a very nice little packing instrument as well. So what I'm going to do now in the video is I'm going to show you cord placement on Connie. Now originally, Connie's sulcus seemed pretty tight to me, even though it's 1.5 millimeters deep, but I thought the tissue seemed not overly thick. So in the video, you're going to see that I decided to try a number 0 cord instead of my usual number 1. because I thought that Connie's tissue was very firm. But the trouble with using 0 or double aught when you want to drop a full crown margin is it often doesn't offer enough retraction. So here what you'll see is me placing that number 0 chord, and I'm placing it, and as I'm placing it, I'm looking to see how much does the tissue move. What I would like is I'd like to see the tissue move about a ½ millimeter, so it's easy to drop my margin a ½ millimeter below tissue. But it's not moving much at all. So I'm going to pull that 0 chord, and I'm going to go to what I typically use, which is a number 1 chord. So here I'm putting in the number 1 chord. You'll notice the way I do it is I like to just pack it around the tooth rather than grabbing and pulling. Some people like to loop the cord and pull. The trouble with that is often it gives you different depths of placement. What I'm doing is I'm intentionally placing that cord so it exposes 5/10 of a millimeter of tooth. And I'll actually even take a perio-probe and I'll measure to make sure I basically have 5/10 of a millimeter of tooth exposed. So here's the left central, and you can see what the cord has done is it's moved the tissue out of the way, and from the top of the cord to the top of the prep, which is where the gingiva used to be, is 5/10 of a millimeter. I'll then go ahead and repeat the same process on the other central. And sometimes where I will have difficulty is I'll use my fingers and basically use it like floss to get it through the interproximal. And if you haven't broken the contacts, you're going to find number 1 chord simply won't go through the interproximal. So I actually had to extend a little farther apically on Connie to get that contact opened up just a hair more. Now I can extend the cord through there easily. Same exact thing. Pack the cord so you've exposed a ½ millimeter of tooth. Now, because the gingiva used to be at where the prep is, you now know exactly what a ½ millimeter is below tissue. There's no question at all. On both centrals, we've got 5/10 of a millimeter of tooth exposed between where the prep margin is and where the top of the cord is. Now, how do we control margin placement? We drop these margins right to the top of the cord. And when we drop the margin right to the top of the cord, our margin is now 5/10, 6/10 of a millimeter below tissue. You'll also see that I put the cord all the way around the tooth, even though I'm not going to drop the lingual margin. I do it simply because it makes a really clean impression, because this cord is going to stay in place. I happen to like a double cord technique. Other people like a single cord technique. What I'm going to do, though, is this first cord is going to stay in place. So I'm now going to use the appropriate burr, and I'm going to extend this prep right to the top of the cord. And the appropriate burr is typically a 1 to 1.2 millimeter burr if you're talking a full crown. I usually use a KS1 burr, which is 1.2 millimeters, and I simply drop the prep right to the top. So there you can see what a KS1 burr looks like. How do you avoid hitting the gingiva? You keep the burr inside the tooth. If you don't prepare deep enough, your burr is going to be outside the tooth, and then you're going to be hitting gingiva. By keeping the burr in the tooth, you guarantee you're getting your 1 to 1.2 millimeters of reduction, and you're not hitting the gingiva at the same time. So on the right screen there is what it looks like after I've dropped the margin right to the top of the cord using a KS1 burr. And clinically, this is what it would look like. So I'm keeping the burr within the tooth, so it's not hitting tissue at all. And I'll do the interproximals first, and I'm going to take them right down to the top of that cord. I will say on the straight interproximal, I usually push the cord about 3/4 to 1 millimeter below tissue. So my interproximal margins usually end up slightly deeper below tissue than my facial margin is. And now, keeping that burr within the tooth, we simply move all the way around and drop the margin all the way down to the top of the cord. Now, at this point, somebody usually realizes that that burr is a round-ended burr. And if I'm keeping it within the tooth and dropping the margin, it has a tendency to leave a small lip on it. And I'll show you in just a moment how you can manage that lip. It's not a difficult thing at all. While I'm now finishing that, I'll also use the same burr because now that the prep's getting more complete, I'm going to take any sharp angles and round them off. So you'll see I'm rounding all the corners, rounding all the junctions from the lingual up into the incisal, etc. And there's several ways to get rid of that lip. You can use a nice end-cutting diamond. You can use a nice fine grit diamond that won't tend to grab tissue and pull the diamond out a little bit from the tooth so it takes the lip away, but even if it bumps the gingiva, it doesn't cut it up too much. For years, what I used is a white stone, and you're going to see that in this video. And I put the white stone in my high-speed handpiece, and then I run it against the shank, or as I'm holding a big KS6, and I shape the white stone to look like, if you will, a KS1 burr. But the white stone doesn't grab gingiva at all. So you can pull the white stone right out, get rid of the lip, polish the margin, and if you hit the tissue doesn't start bleeding. I have to tell you that since Bob Winter came out with this burr kit he did with Brasseler, I'm actually using that 8856016 burr a lot, which is a very nice fine grit round-ended burr. Pull it away from the prep and you can get rid of the lip and you don't have to go to the process of reshaping a white stone. But here you can see I'm holding the white stone in the handpiece, running it against the KS6, shaping it basically to look like a KS1 kind of burr with a slightly rounded end, flat on the very end, and then rounded on its corners. And now I'll take that burr and I can run it, and even if I bump the gingiva, nothing happens. And you can just run that white stone, you can polish all the little junctions, run it all the way around the tooth, and in the process, any of that little lip that was left just gets eliminated very simply without getting the tissue upset in the same process. Now remember, at this point, there's only one layer of cord in there. And what we've done is we've basically dropped our margins 5 to 7/10 below tissue, and we've polished those margins in that place. Now we need to get ready for our final impression. If you were a single cord technique, what you would now do is you'd pull that layer of cord and then make your impression. I personally prefer to use this double cord technique, so I'm now going to put on a second layer of number 1 cord. Now in this diagram we've colored it green, which is really the color of the number 2, but we've done it only so you can see there's a second layer of cord there. Typically for me, 99% of the time on full crowns, I use a layer of number 1 and then a second layer of number 1. Now, what I need you to know is as you pack this, or your assistant packs it, the goal is to leave this second layer of cord between the margin of the prep and the gingiva. You don't want to overpack. It's very easy if you push too hard to overpack, and then the tissue just falls in over the top. So when you look at the cord, right now in this photograph, I've put the second layer of cord in, and all I've done is to push hard enough so the second layer of cord sits between the margin of the prep and the gingiva. It's making space for impression material. So here's me putting in that second cord, and I know in most offices this would be done by the assistant, so it's important they understand this, that as they put this cord in preparation for your impression, that in fact the goal is to pack it so it creates space, not push it so it disappears. So I'm pushing just hard enough to get the cord to stick between tissue and margin. And we'll do it on this one, we'll do it on the next one. On the lingual, you don't need to pack the second cord because I'm supragingival. And you'll notice that I put my cords so they always butt up against each other on the lingual. But in this case, there's really no reason to go ahead and put the second cord all the way around the lingual surface, just because, in fact, the margin's already going to be easily impressible since it is a supragingival margin. Now, a few things about this cord. Aluminum chloride doesn't taste very good, and so this cord was soaked in aluminum chloride, then taken out of the aluminum chloride and just blotted with gauze so that it's not saturatingly wet with the aluminum chloride. Otherwise, if the patient's tongue gets on any of it, it's really not a good taste at all. When I had my own work done, one of my least favorite parts of the whole thing was the taste of the aluminum chloride that was on the cord. How long do you need to leave this in before your impression? research says somewhere around 4 minutes. Now, is there a danger leaving it longer than that? Not really. So what I'm doing is I'm checking to make sure the chord's visible all the way around. When I look from the incisal, that's what I want to see. I want to see that second chord visible all the way around, except on the lingual where I have supragingival margins. If that chord wasn't visible, if the tissue had fallen in over the top of it, I either need to lift the chord up, not pack it as far, or I need to just trim away that overhanging tissue. Because if the tissue's falling over the chord, when you pull it for your impression, the tissue's just going to fall in next to your prep. So this is what I expect the chord to look like prior to being pulled for the final impression. Now, when we pull this chord, we're going to see another 0.5 millimeter of tooth exposed. Because recognize what this second chord did is it pushed the first chord into the epithelial attachment. I promise you the first chord has torn the epithelial attachment. And when you pull this second chord, there will be a temptation to want to drop your prep margin. I would encourage you to be very careful about that, because what you're seeing is this exposure of tooth that we want, because we'd like to get a 0.5 millimeter of tooth in our impression below the prep. But what we're really seeing is the fact that we pushed the first chord into the attachment. That's why we're exposing that other 0.5 millimeter of tooth. And so in this case, I don't see any tissue hanging over the edge. We're going to go ahead and pull the top chord. There's that 0.5 millimeter of tooth I mentioned, but realize that we're seeing it simply because the first chord got pushed farther up. Remember, the first chord used to be right where our prep is right now. And so go ahead, pull the top chord. That's what you should be looking at. Nice, clean, dry, no bleeding. The tissue hasn't been hit by the burr at all. We've got really nice, smooth finish lines. Easy impression to make. And honestly, even if you're using a scanning system to make your impressions instead of silicone, tissue management is still the key. Getting the margins exposed like this is still the key to getting a really clean impression, whether it's an optical impression or it's a traditional impression with polysiloxane or polyether material. So a little trick, when you do pull the top chord, you want to wet it with water first. Wetting it with water makes it so when you pull the top chord, it doesn't pull the sulcular lining. If you dry everything and then pull the top chord, you actually risk pulling some sulcular lining with it, and you'll start getting some hemorrhage. And so if you watch, here's the actual pulling of the cord. I typically will squirt a little water on it, then reach in with my cotton pliers, pull the cord, now dry, and you'll see we've got tooth exposure, we've got no bleeding to deal with, easy final impression. And typically, for years, what I've used is Aquasil Ultra from Koch for my impression material. I happen to like the extra light viscosity. I just put the tip right on the margin and scrub as I inject. And I don't blow air usually at all unless I see a little bit of hemorrhage or unless I have very, very tight tissue and I just can't get that exposure of the sulcus that you see here. And then I actually inject it on the occlusals of all the other teeth. My partner Greg Kinzer injects it on the tray, the light body on the tray material to pick up all the posterior teeth. But you do need to get some syringe material back onto the occlusal surfaces, otherwise the tray ends up typically with a lot of voids. And there's the impression of those two central incisors. You can see we've got our nice 1.2 millimeter chamfer all the way around. And even after the impression's pulled, if you needed to make a second impression for any reason, no problem, there's still a lot of retraction there. Now, if you pulled that bottom cord, what you would find is going to bleed like crazy because it's in the attachment. So what we do is we make our temporaries typically, finish them, cement them, and then pull the bottom cord. Now that doesn't always happen. Honestly, sometimes the impression pulls out the bottom cord because the impression material sticks to that cord and pulls it out. Just realize when that bottom cord comes out, you're going to start getting hemorrhage. And so you want to get your impression made prior to that bottom cord coming out. The beauty, if you can leave it in until after you cemented your temporaries, is that now when you remove the chord, you know there's no temporary cement in the sulcus. So here's the temporaries on Connie's case. They're cemented with caulk phenol, F-Y-N-A-L, which is a reinforced ZOE. So here they are. The cement is hardened. We're now going to clean the cement off. But once we get the cement cleaned off, we're then going to pull that chord out. And in pulling that chord out, we're going to make sure there's no cement left behind, because temporary cement left in the sulcus causes a tremendous amount of inflammation. And then the day you go to seat the final restorations, now you're fighting dealing with inflamed tissue. Whereas if we've made really well-fitting temporaries, and we've made sure we don't leave any temporary cement behind, we're not going to have inflamed tissue at all. So there's getting that bottom layer of chord out. As I said, typically what will happen is as soon as it comes out, you're going to start to see a bit of hemorrhage. If you needed to make a second impression and the bottom chord had come out in the first impression, the trick is put another bottom layer of chord in. And as soon as you put that new bottom layer of chord back where it used to be, typically with a little aluminum chloride on it, the hemorrhage will stop pretty readily. And so just making sure we're not leaving any temporary cement behind, which, as I said, pretty unusual if you've done this the way I did by pulling the chord out after everything's cemented, using a little super floss to make sure we're not leaving any cement interproximally, because if we don't open that embrasure up, we're going to have a papilla that's blunted, and the day we try and seat our finals, we may have a little black space there. Bottom line, here's what Connie's temporaries look like when she came back the day of seating. We're going to take them off with some hemostats. This is what the tissue looked like underneath. We've got our margins 5/10 below tissue. We've got healthy tissue. Don't have any inflammation to deal with. In this case, they are lucite reinforced pressed ceramic, chosen because the ingot color matched her teeth really well. They've been cut back incisally and on the facial a bit, so the technicians layered powder and liquid ceramics to get the aesthetic effects that we wanted. And then they'll be bonded in place with some sort of a total etch, either light cure system or dual cure dent adhesive system and cement. We talk about that in other sections. But here you can see Connie going from where she started to the final result. And honestly, having the margins a 0.5 millimeter below tissue does make it more perfect, if you will, in terms of how these crowns look. And is there a risk of recession? Really small. What would have to happen for her to get recession? She'd have to have her tissue migrate apically, which would mean her attachment migrate apically, and that's not going to happen unless the bone migrates apically, because Connie has a very shallow sulcus depth. So there's just the before and afters with our two crowns, literally right after they were cemented. That's how they blend in with the adjacent teeth, and there's her smile before and after. So I hope this helps you understand subgingival margin placement, at least the way I like to look at it, and gives you a technique for how to control it, how to know exactly where your margin is in a very, very controlled way, and control the tissue so it makes your impression making much easier as well. It's been my pleasure to share this with you, and I look forward to seeing you again soon.